thank you, the organizing committee, for this opportunity to speak. It's truly honor, as an engineer, invite to speak here to talk about this important issue. Here's my disclosure. Well, systemic inflammatory response syndrome is a serious condition in which there's inflammation throughout the whole body, a clinical response to a non-specific insult of either infectious or non-infectious origin. And it may be caused by severe infection, trauma, shock, or other medical conditions. It's marked or diagnosed by two clinical manifestations like fast heart rate, low blood pressure, low or high body temperature, high respiratory rate, or low and high white blood cell counts. Well, SIRS can evolve into sepsis when there's infection confirmed, or further to severe sepsis with organ dysfunction, hypertension, hyperperfusion, or even become septic shock when there's organ dysfunction, even with fluid resuscitation. Furthermore, you can become multi-organ dysfunction syndrome with two organs failing. So SIRS is critically related to the cytokine release. Inflammation response is occurred when a tissue was injured or by bacteria, trauma, other issues. Then the damaged cell release cytokines. This chemical can cause blood vessel swelling, blood become leaking the fluid out there, also attract white blood cells to eradicate germs or dead cells or damaged cells. This helps isolate foreign substance from the contact with body tissues. Cytokine release can also happen when white blood cells become activated, release inflammatory cytokine, which in turn can activate more white blood cells. This is the vicious cycle. So how device therapy relate to cytokine release? Well, when we put a patient on device therapy, two things happen. First thing, we introduce blood to foreign materials, which is artificial surface. So coagulation, activation, cascade, complement activation happened. So the platelets, white blood cells become activated, they release cytokines. Second thing happens is when we put the blood, subject the blood to a non-physiological shear condition. So you know the shears, as a force. When you drive the car, you drive 40 miles, other people 60 miles pass through you. You can, even though they don't touch you, but that force you can feel. Same thing in blood cell with shear stress. One part moving very fast, another part very slow. When the shear stress high enough, you can really deform the cells or get mechanical damage or chemical damage to the cell. This is show the picture when the shear stress high enough can rupture the red blood cells or other bloods in it. So here, under physiological condition, maximum shear stress in the circulation system is less than 10 Pascal. But when we put the device into circulation, then you see, this picture shows here central mag pump used to generate blood flow 4.5 liters per minute against three different conditions. 75 millimeter pressure, minimum mercury pressure is pretty much similar like implant ventricular assist device, the pressure 75. 150 millimeter mercury is similar to extracorporeal blood pump support. 350 millimeter mercury equivalent to like ECMO, VA ECMO condition. You can see the shear stress almost, some spots can be as high as 500 Pascal, which is almost 100 times higher than normal physiological condition. So when we subject blood to this condition, what happens, we did in vitro experiments, which put the blood into in vitro device assisted circulation for 4 hours. Then, on the three different conditions, you can see here, on the 75 millimeter mercury condition, the damage, platelet activation damage, is minimal. But when you look at the 150 million mercury and 350 million mercury, almost 15% platelets become activated. Platelets become activated, then release cytokine or other internal chemicals can trigger some inflammatory response trigger. Also, in the meantime, this shear stress can really damage red platelets. On the right side, two figures, it's receptor shading, which basically mechanical device causes the loss of the receptor. Glycoprotein 6 is collagen receptor. Glycoprotein won't be alpha, it's VW receptor. They're essential for hemostasis. So when the platelets, when you need it to do the normal hemostasis, then they lost the receptor, then they cannot function normally. Recently, we're also looking for leukocyte activation. When we put the H values assisted circulation in vitro, you can see the marker one is leukocyte activation marker, neutrophil activation marker. So after 4 hours circulation, almost 30% leukocyte become activated. And in the meantime, receptor, CD62, L-lectin also get shed away. Basically, they rupture, rip it off all the receptor on the surface, which is, this receptor is essential for leukocytes, lowering adhesion on the endothelial cells and the transmigration. We also exposed the blood to single pass shear exposure. After exposed blood to 75 Pascal for 1 second, you can see internally there's a production of reactive oxygen species. So basically something damaging effect. Also, we can see the receptor shading, activation on the marker one's receptor for the leukocyte activation. So also we analyze blood sample for the patient on VED support. Before the put the device on, we can see there's progressive production of reactive oxygen species in the immune cells. And then also observed there's DNA damage process ongoing after, before surgery, and the device put it on. After 3 months, you can see progressive increased. The green dots, it's represented DNA breaking down. And then this marrow 11 is the the marrow 11 is the DNA repair protein. So you can see this ongoing clinical process, DNA damage repair. We also observed, the leukocyte activation in patient blood sample. MPO and PMI elastase is soluble biomarker for leukocyte activation. So you can see when patient develops systemic inflammatory response, the leukocyte activation level is high. So in summary, when you put a device on patient, support a patient, you can stabilize hemodynamics, restore perfusion. But in the meantime, please be mindful, you create a non-physiological condition which can, one side cause leukocyte white cell activation, then they can release cytokine, then trigger the colonical systemic inflammatory response. Other side also can damage blood cell like leukocytes. The immune function or defense function will be weakened. So this one. So what you can do, not much you can do for the device surface area, but what you can do, maybe after stabilize the patient, what you can do really you can think about it, maybe you can change the operating condition in the device. For example, you can combine some drug treatment with the device after you stabilize. Thank you.
Dr. Wu, I want to ask you 2 questions. Thank you. It was an excellent talk. And very obvious that you are an engineer,
Yes.
as everything was math. I I want to ask you, related to the information that you presented regarding the SIRS response with the Centromag and talked about activation of platelets, how you believe you think that this does this. Have you done any proteomic or any protein studies to look for factors or specific proteins that are specifically elevated or attenuated in this cytokine response? And the second question is that when you were talking about being put on support and about free radical oxidation, do you know what percentage of oxygen those patients were on, or the PO2 of those cells when you were looking at them? Because we were clearly looking at cells, but I wasn't looking at a human being. So,
yeah. Well, the first question, I have not done that part, but this is the process we're planning in the future. Probably we'll be looking for the protein key. Even sometimes we're thinking about maybe before the surgery would be probably screen the patient based on their pre-surgical, some biomarkers, and maybe can stratify patient. Some patient may be more vulnerable, more risky to something happen. So I have not done that part. For the second question, we just taking the blood from the sample, so it's a normal, I think just like a normal PO2 in the bloodstream. So we're just looking for but that's internal oxidative stress inside, so probably not much related to actually arterial.
I mean, one of the reasons I ask is that, in the translation of science, even if we use a normal blood PO2, the penetration of oxygen to the middle of the myocardium is significantly lower than we would otherwise expect. So otherwise, normal PO2s can cause injury. And on ECMO, depending on the center, we're typically not that careful about what's going through the circuit and what's going through the patient. It's not uncommon all the time to see PO2s of 150 in these patients for a week, and I think that's profoundly deleterious.
Well, that's a perfect question. Actually, we also think about that because right now we need to put the patient on ECMO support. People talk about we need a PO2 300, which actually that's beneficial or not. In a normal value, our PO2 is probably 150, 140 minimum mercury.
For the PO2, there are different aspects. I think that we have the reaction of the endothelium, which is quite interesting because on the venous side, it is a little bit less sensitive to hyperoxia than on the arterial side, paradoxically. But also what we perhaps should not neglect, as you mentioned, is that inside the circuit itself, it is submitted to a very high PO2, or whatever we do, because it's indeed what we intend to have. And the in vitro reactions are not well defined at this stage. So I think that, and we probably have nothing to do to try to limit this, because we still will have significant hyperoxia in the circuit itself.
So if you were to do an experiment with the patients on long-term LVAD support, like the HVAD, CRP over time, what would you predict? So CRP at, pre-op, 1 month, 3 months, 6 months, 1 year out, what would you predict?
Well, I would think about before surgery, probably have certain level, then immediate surgery because your trauma, your surgical trauma, then a little bit spark it up. If the patient respond to the support well enough, they can become normalized. But if they don't, then probably we remain elevated. Then that probably somehow relate to the ultimate outcome.
We're going to have data presented at, let's see, did we submit the abstract? This is the work of an ex-fellow of ours who's now our director at HUP, Ido Baratti. His first idea that he came to us is, why can't pump thrombosis be like MI? And inflammation be a big need. I said, Ido, that's a great idea, but we took, of course, like things in our field, 6 years, 5 years to do this. Endurance is done. We did it in endurance. We just submitted the abstract, I think, to a SIO way back when, so it may be presented at a SIO. But the data look very interestingly, and I can tell you this, we're going to present it at SIO. You were basically decreasing CRP over time pretty impressively. So I was just going to ask you, do you think there's, CRP is, I'm not a scientist on CRP, but it seems to me like focusing on white cells only, like you have, very important. from a bioengineering point of view, but do you think there's counter-regulatory pathways that make overall inflammation better on a VAT? And by the way, it's still abnormal, it's still high, but it's much lower than you started with pre-LVAD. Pre-LVAD.
Yeah. Well, I was thinking about all the, like molecular biology side, everything interrelated, so something happen, like, as we talk about, we're looking for platelets, leukocytes, after you talk about this, more people talk about hemolysis, all actually, when you have a hemolysis, suddenly you have cell damage, you release cytokine, TNF-alpha, interleukin-1, all they come together. So this is what I talk about. So like, when the patient is shocked, probably first thing you need to do, no matter what you do, you stabilize the patient, just get hemodynamics under control. After that, maybe begin to think about what is best strategy to treat the patients. Like if you keep high dynamic, it's more important or just overall structure and the body response. So that's why it's like a comprehensive. Yeah.
Two questions, Dr. Wu. First, you examined varying outlet pressure conditions. Did you examine varying blood viscosity? Because that obviously is that's the physical basis for impedance is viscosity.
Yeah, we actually, when we get the blood, we always adjust the blood, the patient blood to the 30% hematocrit, make sure the hematocrit is the same. Viscosity is slightly different, but then when we just do multiple patients, the donor blood, and so we get that averaged out the difference.
Okay. And the second question then, just very quickly, is with a view towards therapy, obviously we've known for a very long time that artificial surfaces cause activation of the innate immune system and result in inflammation. That's why, for example, leukocyte filters have been in use in cardiopulmonary bypass circuits for decades now. What would you do about this in a chronic LVAD-supported patient? What can you do?
Well,
it's not a 4-hour pump run.
Actually, it's my opinion. Actually, I think today the surface become less relevant because you can think about ECMO patients. Still important part. But you can look at ECMO patients live 100 days, 200 days. So if they give that kind of high inflammatory status, then probably kind of doable. Well, actually, we just did one experiment study. It's an interesting thing. We put it like a central mag pump, small oxygenator, and just central mag pump alone, looking for inflammatory markers. Mm-hmm. Actually, they're pretty much the same, So that we can reproduce results very soon, but it's just really, I don't see. So, because surface area with oxygenator is like a 0.4 square meter, another central mag without that surface area, just central mag pump. We're looking for like TNF-alpha, interleukin-1. The results pretty much the same.